Dr. Manston. Appreciate that. Everybody hears me? Jason, you hear me?
Yes, we can hear you.
Okay, good. So for those of you who don't know me, probably everybody knows me here. My name is Marzieh Golbar, and I am an opioid stewardship and appropriateness pharmacist. Thank you very much for tuning in. I'm talking a little bit about low-dose naltrexone and examine the idea of how innovative approach is that, in fact, in inflammatory diseases. So let's get it started. First, I would like to acknowledge that we are gathering on Treaty 2, 4, 5, 6, 8, and 10 territory and homeland of Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous people. I pay my respect to the traditional caretakers of this land. For objectives of this brief presentation, we'll just go over naltrexone, an overview of what it is, rationale, dosing, goals of LDN therapy, mechanism of action, some proposed indications, advantages, concerns, preps and dosage forms, and some conclusion notes. By far, most of the study that has been done, it has been involving fibromyalgia, Crohn's, multiple sclerosis, and complex syndrome. Mostly this presentation will be focusing on the first two, but when I say focus, I'm not going to go into much of a detail, but the studies are available if you want it. Definitely they are interesting. I encourage you to read them. There has been evidences that LDN may in fact be reducing symptom severity in these conditions. It does act on microglial cells, which we will see in more detail. And these effects are unique to lower doses of naltrexone. And since the first study that was published on LDN as a trial on humans in 2007, and there has been very low sample sizes, which you will see, and very few replicated studies. So this is a very highly experimental area, and be very careful how to interpret this information that I'm giving you in this presentation. And in fact, yes, LDN may be representing one of the first glial cell modulator to be used for management of chronic pain disorders. So, inquisitive mind, they will wonder, how did that happen? How did they find out? This Dr. Bernard Bahari, he's a physician in New York City. In 1985, as he was treating his HIV patients, he noticed that dosage as low as 3 milligrams of naltrexone given once a day can actually improve this HIV patient's immune response to infection. Later on, during that continuum of his work in 1990s or mid-90s, he found out that patients with lymphoma or pancreatic cancer, in some cases, they show remarkable improvement. Also, autoimmune diseases such as lupus, they showed a prompt control of disease progression in some cases. So a little overview of the molecular formula. If I'm seeing it right, it looks like it has 6 rings. It's considered an antidote to opioid competitive antagonist. And the approval for opioid use disorder and alcoholism was approved by FDA on November 20th of 1984. From moderate to severe alcohol use disorders, 25 to 50 milligrams once a day, and may increase to 100 milligrams once daily thereafter. After a week, for mild to severe opioid use disorder, it's 25 milligrams once a day for 1 to 3 days. And then if there are no withdrawal symptoms, it could go up to 50 milligrams once a day thereafter. For pruritus, if it is either produced by opioid or non-opioid induced, the oral dosage range between 12.5 to 50 milligrams once daily. And probably it's not a coincidence that you see that it falls on the lower side of the spectrum of dosage for naltrexone. Some pharmacokinetics, kind of a dry subject, but let's see. Oral, 50 milligram, 100 milligram doses, they are quite related to 24, 48, and 72 hours of duration, with IMP 4 weeks and duration. Absorption orally, almost complete, with a large volume of distribution, and of course, the inter-individual variation exists. Protein binding 21%, and oral bioavailability, the range, again, 5 to 40%. And time to peak in the serum concentration with oral would be nearly 60 minutes. For IM, in 2 steps, first peak in 2 hours, almost, and from 2 to 3 days for the second phase, for the second peak. Oral dosage form, of course, it goes through extensive first pass effect, and it's metabolized via non-cytochrome-mediated dehydrogenase conversion to 6-beta-naltrexone, which is a primary metabolite, and some related minor metabolites and glucuronide conjugates. Half-life elimination for oral parent compound is between 4 to 6 hours. 6-beta-naltrexone primary metabolite is 13 hours. And for IM, both molecules appear to be between 5 to 10 days, depending on the erosion of the polymer. And they are excreted primarily through urine as metabolites and small amounts of unchanged drug. So the studies did show that a range of dosage between 1 to 4.5 milligram of naltrexone given once a day at bedtime. It could be used with the, of course, the dosage increase of between 2 to 4 weeks intervals. Of course, ADRs and efficacy must be monitored. But first, there are a couple of things to consider. Currently, there are no guidelines for the usage of LDN, and neither there is an FDA approval for naltrexone to be used at any dose for any inflammatory conditions. This refers to a very small study involving 10 women. It's a single-blind crossover trial. Naltrexone has been provided also, the subject received both placebo and LDN at the dosage of 4.5 milligram once a day. The placebo group did not show any association with pain relief, but the group that was treated with LDN, they showed a pain relief. But here, consider that there is an inflammatory marker of ESR, erythrocyte sedimentation rate, for those patients who had an elevated ESR at the baseline. Those are the ones who reported pain relief with LDN. And that we are talking about 30% of reduction in symptoms compared to placebo. So in other words, those who had elevated ESR levels, they had the greatest positive response to LDN. And of note is that the duration of illness or baseline symptom severity did not predict a response to LDN, but the marker of inflammation showed a relationship. In another study involving 31 women again, and it was a randomized trial, it's a double-blind crossover study, there has been self-reported, I guess, in terms of pain improvement. 13% you see is very much improved. Much improved is 37%, so it accounts for about 50% of improvement. And 20% were minimally improved, 20% thought there was no change, and 10% thought that they were a little worse. And that was also involving LDN 4.5 milligram once a day given at bedtime. So as rationale, LDN could be on the horizon for a monotherapy, even for chronic pain or inflammatory origins. Its paradoxical properties of analgesia, for example, at lower dosages, that provides one rationale. And then the enhancement of endogenous opioid production, we will talk about that more. In 1980s, it has been discovered. So look at these, but be cautious as to how you interpret this information. So how does it work? As a glial cell modulator, it has an endogenous effect on opioid receptors, with Toll-like-4 receptors, Toll-like-4 or TLR4. These are found on the surface of macrophages, such as microglia. And here I have to explain a little bit so that we know the characters of glia or macroglia or astrocytes. These guys are all considered glia. These are in central nervous system, especially macroglia. Some researchers refer to them as bad guys. Even astrocytes sometimes referred to as bad guys, but I'll get to them. At this time, let's just deal with microglia, which are the glial cells. They are throughout the brain and the spinal cord, and they account for 10 to 15% of cells that are within the brain. Now, I will not be too critical of them because they are our first and main form of active immune defense in the central nervous system. But consider a phenomenon such as opioid-induced hyperalgesia. It is not just low-dose naltrexone, but also opioids that they act at toll-like receptors or TLR4 receptors. But opioids have, I would say, it's an activating effect at these receptors as opposed to LDN. So in response to repeated administration of opioids, glia can become increasingly activated, and then they cause increasing neuronal excitability, meaning upregulating excitatory receptor functions and regulating the downregulatory inhibitory receptors. They will be also downregulated, so kind of inhibitory action on downregulating pathways. So this will all go to amplification of pain as a result and suppressing acute opioid analgesia, which in turn produces tolerance and opioid dependence and opioid use disorder. As far as LDN is concerned, recently it has been discovered that naltrexone really is a 50-50 mixture of both D and L isomers, which is dextro and levo. These enantiomers, they have distinct, very, very different biological activities. The L isomer is the one that we all know. It's an opioid antagonist at mu and kappa, and to a lesser extent at delta receptors. And the D isomer is the antagonist for certain immune cells and the toll-like receptors for, which is TLR4. So this considered a downregulatory series of steps orchestrated by the D isomer, which brings about a decreased production of pro-inflammatory cytokines, decrease in tumor necrosis factor alpha, decrease in reactive oxygen species, and the NF-κB molecule, which is involved in cellular resistance to invading pathogens. But the final outcome of this, downregulating that and downregulating this, they all will be reduced inflammation. And on a side note, I tell you that there is a potential downregulation on oncogenes, which are mutated genes that they can cause cancer. And also conditions such as fibromyalgia, that they are thought to involve chronic glial cell activation and pro-inflammatory factors. And you see how LDN can have implication here and how this mechanism of action is actually relevant to diseases such as fibromyalgia. Having said this, naltrexone is not a full promise of glial cell modulation, and it's perfectly okay. I mean, you are seeing here that we have a few other places or sites of action or modality of actions for LDN, which is good. Consider that you are attacking a problem from several directions as opposed to one direction. This is good, but this slide, I guess I'm just saying that the pathway, the key pathway as to how LDN works is not known right now, but definitely you can consider a glial cell modulation component to the way it works. It also has other suggested targets like astrocytes and NADPH oxidase 2. Astrocytes, again, they are glia. They are called bad guys. They are larger neuroglia, though, compared to microglia, and they are accounting for about 45 to 50% of cells in the central nervous system and brain. They are irritable. They are excitable. You don't mess with them very much. And they involve in pro-inflammatory cytokine production and inflammation. And as for the other molecule, NADPH oxidase 2, it's a membrane-bound enzyme complex. And I don't know if you can see this, but this is what this little diagram refers to that. It is thought to play a pivotal role in inflammation-mediated neurodegeneration through the pathway of increased reactive oxygen species. Now, this is not a physiology class, but I'm just trying to make this a little bit better understanding. Why do we say these are different modalities of action? Because they are truly different sites that LPN may be working at. So NADPase oxidase 2 activation brings about even more superoxides and more species, different other kinds of oxygen reactive species, and more microglia activation and more inflammation. And continued to the sites of action or different modalities, opioid growth factor seems to be another area, which I will explain. The doctors, professors in the Department of Neural and Behavioral Science, Pennsylvania State Cancer Institute, Dr. Ian Zagon and his colleagues, they demonstrated something called opioid rebound effect. How did they do that? They had this experiments, and then during what they were doing, they found out that a small transient opioid blockade, it can lead to an opioid upregulatory mechanism. And they call it opioid rebound effect, which makes sure that there are more opioid-like stuff around. How does it do it? This is my own diagram, by the way. I try to illustrate this as best as I can. So consider the patients starting with a low-dose naltrexone. And this low-dose naltrexone is being administered only once a day. This will create an intermittent receptor binding, which in return, it causes inhibition of DNA synthesis, inhibition of cellular proliferation of T and B cells, which at this point, a compensatory mechanism comes into play and starts making more opioid growth factors, because he wants more of those around, and more of the receptors and their improved sensitivity. Opioid growth factors are now known to be called endorphins and enkephalins. Where these enkephalins are, it's not coincidental. These guys are very close in terms of proximity to opioid receptors, or they act on opioid receptors that are positioned on the terminals of sensory fibers. So when a stimuli comes, the substance P will be produced and produces all those pain and inflammatory cascade just keeps going. At this point, when enkephalins are produced, they can inhibit substance P right on the spot. So they are produced where they are needed, when they are needed. And of course, causing pain through nociception, that's the job of substance P. It's a neuropeptide, I'll have all those fancy names, neuropeptide, neurotransmitter, neuromodulator. That does all of those for pain sensation. And that's where it's exactly opposed by the action of enkephalins. I think I explained it very well, but let's reiterate. A brief period of opioid blockade can increase adaptive increase. It can create an adaptive increase in endorphin and enkephalins, and more of those things around. Of course, more of the opioid receptors will be responding to them and producing analgesia, and a very good effect, a very positive upregulatory effect on the immune elements. So some of the proposed indication, basically anything with inflammation at its roots. But this, remember, this area is very highly experimental. For neurologic diseases, for example, Parkinson's disease or headaches or restless legs, ear, nose, sinus, throat, that good old Meniere's disease can be treated perhaps, or it became a candidate for LDN treatment. Cardiac disease, like a autoimmune cardiomyopathy. In dermatology, something like alopecia and vasculitis can possibly be a candidate for LDN therapy. GI disease would be the Crohn's. Infectious diseases such as Lyme disease, herpes zoster, or even COVID, but I would put a question mark in front of it. The most difficult to see here a rationale in terms of how LDN can contribute to any good effects would be psychological disorders. But remember that endorphin deficiency could be playing a role in psychiatric disorders such as depression or emotional instability or self-hurting thoughts or behaviors. And the adaptive increase in endorphins, I think LDN could be in a position to treat these things, but that has to be still discovered or experimented upon. So yes, by far, Crohn's disease has the most scientific support for LDN therapy. And there have been reductions reported in self-reported pain, objective markers of inflammation and disease severity, and the severity scores from endoscopic evaluations. As a secondary outcome, the mucosal healing based upon colonoscopy appearance and histology in colon and ileum, they have been reported. Almost like 78% of the subjects in this study, they are adults, male and female, age 18 and older. 40 subjects, this was a double-blind study of 12 weeks treated with 4.5 milligram of LDN once a day versus placebo. And they did report a 5-point decline in this particular measure. Like I'm going to state that it's probably not much meaning, but I don't want to say it doesn't have a meaning, but it's probably not something we encounter every day, but it's a 5-point decline in the Crohn's disease endoscopy index severity score compared to 28% decrease versus placebo. So I'll just keep that at that level. If you want this study, I can send it to you. It's very interesting. And you'll see that over 80% of the study participants, they showed significant improvement. And this is a better response rate to fibromyalgia. There are also other promises in disease severity, improvements in multiple sclerosis as far as spasticity is concerned. Some reports of reduced spasticity and improved mental health have been reported. Complex regional pain syndrome, they are thought to have some inflammation at their origin, whether it would be a systemic, a low-level inflammation, or locally. There has been studies that limited case evidences that actually LDN has been showing some efficacy in that area. So these studies also say that it's inexpensive, but I would kind of think that it's probably not the case because compounded capsules, I have had patients who were quite displeased with the fact that they have to pay $200, nearly $200 for a month of 2 milligram capsules. And this is given once a day because of the dosage, the regimen for LDN. It's for a month supply, but not everybody is able to pay $200. So maybe there is a rationale for pharmacists to step in and to discuss the possibilities of coverage with Saskatchewan Drug Plan. If there are patients who are refractory to treatments or they cannot tolerate the conventional therapy, then they would probably appear on an EDS. I mean, I think this is a very logical, reasonable ask. As for the side effects, NSAIDs, we know them. They cause ulcers, they have renal insufficiency, risks with warfarin and other popular medication interactions, cardiovascular risks such as clotting or heart attack. And these have not been observed with LDN, but more studies are needed. I have to say that with every slide, and I would say that because I want this to be taken very objectively. As for the side effects, the adverse reactions, the vivid dreams, they have been reported with the first dose. And obviously, you see that 30%, 37% of subjects, they say that they have this, but also this has been reported with placebo. So really, more studies are needed to see what's causing what. But the sleep effectiveness, they have been reported to improve. A few negligible cases of nightmares and some reports of headaches, but this has to be taken with more thoughts because it's also expected with fibromyalgia. Spontaneous headaches were in fact regularly the case in all phases of the clinical trials. So more evidence is needed. Some anxiety, tachycardia, these guys have not been observed in research, but some doctor-reported cases. Makes sense. And LDL is opioid receptor blockade, and the endogenous opioids also, it includes them. It doesn't really mean that it has to be competitive action for opioids that are being prescribed. No, these are also for opioids that your body produces them too. And of course, at much higher doses, naltrexone doesn't seem to be doing much with hepatic enzymes. So if patients are not hepatically impaired, maybe LDN can be considered with a peace of mind, but monitoring has to be going on. It has to be ongoing. Reports of toxicity with LDN has not been reported, but then again, this has to be taken very carefully because what are the sample sizes? How many studies have been there anyway to draw a conclusion that this is absolutely safe? So what are some concerns with LDN? One of the concerns with that is the patients preparing their own doses. They have to split 50 milligram tablets. But that being said, there are also internet sources that exist, and the patients have been resorting to cutting or splitting, how to split the 50 milligram tablets or how to create a solution and then divide out liquid doses. Very variable, very, very inconsistent, and far from optimal. This is not what you want to do. And then again, is the lack of proper dosage finding. This is important. We don't have, I mean, it's very rare for a pharmaceutical to have one size fit all dose. Inter-individual differences must be considered. BMI, metabolism, opioid receptor sensitivity. Now remember, the opioid receptor sensitivity is different from patient to patient. Microglia sensitivity to LDN, that's another one. It's not the same with two people. Maybe most patients, but it may be similar, but not the same. And dosage range. What is the safe dosage range here? What is the optimal dose for an individual? Maybe 4.5 milligram is not really optimum for somebody, maybe 6 milligram, maybe 7 milligram. It all has to be considered. Some dosing strategies also, it's quite important. Some animal studies show that LDN, if it's used in a typical fashion, which is once a day, it reduces tumor growth. But if it's used twice a day, then it can increase the possibility of growth of tumors. Like it can enhance their possibility to grow. All of these have to be considered. And it says no statistically significant data in long-term safety. It's absolutely correct. How do we know if we tease these members of our immune system, what are we going to expect in the long term? How are they going to behave? But remember the adaptive increase in opioid growth factors from that pathway, opioid growth factor and binding to the receptors of LDN because of the once-a-day dosing, intermittent binding. There is a study that actually examined lymphocytes. These guys have surface receptors for endorphins and enkephalins. Some studies, I mean, this particular one shows, which I'm going to provide, if you want it, I can send it to you, but I'm just tell you about it. Some lymphocytes, they actually showed the possibility of proliferation and the natural killer cytotoxicity enhancement. Also, increase in antibody synthesis. Maybe this is also considered light at the end of the tunnel, but you really have to study this more, and we have more work in this area to kind of decide what to expect. How is this going to act? These mechanism of action on one end and another mechanism of action on the other. What is going to be happening between them and who will be dominating? And of course, insurance companies, they do not consider this a real treatment. They say this is an off-label approach to treating these inflammatory diseases, so they don't cover it, they don't recommend. As for the dosage forms, in Canada, you just have the tablets, either name brand and the generic, and in the US, there is an intramuscular injection, 380 milligram per vial, and 50 milligram tablets. So we are at the conclusion. Quite a short, I guess, presentation, but maybe a little bit of thoughts here. By far, the sum total of basic and clinical studies, they suggest that LDN may be a favorable treatment for conditions that have inflammation at its roots, an underlying origin of inflammatory conditions. But before LDN can be broadly recommended, it has to be benefiting from more supporting information, more clinical trials, more studies, and replicated research is needed. Important variables such as dosing is yet to be fine-tuned. We have to find the best dosage range, what is the safest, and the dosing strategies, of course. LDN may be utilized as a glial cell modulator, but it's not the sole mechanism of action. It has other areas that it works on. And given the fact that it works centrally, as a centrally functioning immunomodulator, it does not have to be crossing the blood-brain barrier, and which is the opposite, which is on the opposite side of popular anti-inflammatories. They have to, they are bound by their penetrability of BBB or blood-brain barrier. So definitely LDN is going to be in the spotlight of future interests, but with more and more studies and I guess all of the goods and bads and pros and cons to be considered. More new studies are also coming. So thank you very much for being with me on this. And if there are any questions that I can answer, would you please?
Thank you very much, Marzieh. Are there any questions? I don't see any in the chat, so if anyone has anything, you can unmute and ask away. Oh, looks like
stop sharing.
Is that Colin? Oh, no, I think Colin was clapping. There we go.
Oh,